Hello, I'm Dr. Chris Thompson from Brigham and Women's Hospital and Harvard Medical School. And today I'm going to be lecturing on a topic that has been of great interest to me for some time, and that's endoscopic small bowel therapies and the management of obesity and type 2 diabetes. Here are my disclosures. I'd like to start by covering type 2 diabetes, some background and surgical treatments, and we'll focus there on some important concepts, including the incretin effect and foregut and hindgut theory. And from there, we'll delve into the specific small bowel therapies. Type 2 diabetes is truly a pandemic. It's affecting the entire world. I don't need to belabor this point, but you see it in North America, South America, Middle East. It's quite a problem, even Western Pacific. And to understand how we're going to treat this with endoscopic devices, we have to understand the incretin effect. And this little graph will help with that. You can see on the y-axis, we have insulin, and on the x-axis, we have time. And this is what happens when we give a healthy patient glucose. So when we give them the glucose intravenously, they make a certain amount of insulin. Okay, when we give that same subject the same amount of glucose orally, they produce much more insulin. And that is the incretin effect. And we think that this is due to the production of incretins from enteroendocrine cells in the small bowel. And this can be in response to various stimuli, including food, short-chain fatty acids, bile, and in particular, secondary bile acids. And there are various types of incretins. Perhaps the best characterized is GLP-1. This does a lot of things. It not only does it increase insulin production, but it crosses the blood-brain barrier and increases the sense of satiety and fullness. It slows gastric emptying, decreases glucagon. So it does a lot of other beneficial things as well. Now, in type 2 diabetes, this incretin effect is rather blunted, okay? It's substantially reduced. And the concept of surgery is trying to reconstitute that normal curve, if you will. And there's several different types of surgery, and they're all effective, of course, in weight loss and ultimately do have a positive impact on type 2 diabetes. But we do know the ones that have a larger kind of bypass of the small bowel have more direct and immediate effects on type 2 diabetes than these other procedures really seem to have more secondary effects due to weight loss. This was a nice randomized trial from a group in Italy, the senior author being Francesco Rubino. And they took basically patients and randomized them into one of three groups: medical therapy, gastric bypass, or biliopancreatic diversion. And this is in the treatment of type 2 diabetes. Their primary outcome was success at 2 years as defined by an HbA1c of less than 6.5%. No one in the medical therapy arm achieved that success. 75% of the gastric bypass patients did, and 95% of the patients with a biliopancreatic diversion did. So clearly, surgery is doing something rather important. Surgery is very effective. However, surgery alone cannot contain an epidemic. We do need other options. Not everyone is going to qualify for surgery. And less than 1% of eligible patients who are currently eligible undergo surgery. So there's definitely a need for other approaches here. Now, endoscopic bariatric metabolic therapies take several forms. On the left here, we have the gastric devices, space occupying, such as intragastric balloons, gastric remodeling, including ESG or POSE, outlet obstruction, aspiration therapy. Now, all of these have been shown to have an effect on type 2 diabetes, but it is thought to be due to weight loss. What we're talking about today are the small bowel devices, the enteric devices, that are thought to be more metabolic in nature. Okay, the liners or sleeves, duodenal mucosal resurfacing, anastomosis devices, and again, these are thought to be more direct, have more direct effects on type 2 diabetes. So one other concept we want to get into here before moving on is foregut and hindgut theory. And here we have an image depicting normal anatomy, and you can see that the white dots are these cells that produce incretins. They get denser as you go farther down in the small bowel and even into the colon. They're very dense. These are the cells that produce things like GLP-1. And then the black dots represent an anti-incretin effect. Now, it might not be a cell producing anti-incretins, but the concept here is that there is a balancing force at play that prevents people from becoming hypoglycemic, okay? And a gastric bypass affects both of these. It upregulates the incretins and downregulates the hypothesized anti-incretins, all right? A liner does the exact same thing, okay? It is sheltering the duodenum from food, downregulating anti-incretins, and it is dumping food more distally, okay, and preventing the mixing of bile and pancreatic juices with food, causing an augmenting or upregulation of the signaling. So this is the endobarrier. It's a randomized blinded pilot study looking at 18 patients. This was one of the early studies. They had 24-week follow-up. 12 patients had this sleeve placed, released in the duodenal bulb, and then it really spans the entire duodenum. And 6 patients had a sham procedure. The endpoints here they were looking at was hemoglobin A1C and a 7-point glucose profile. They also looked at diabetic medicine use and weight loss. The device is rather easy to place, sort of like a stent. It does require fluoroscopy. So here you see the results at 12 and 24 weeks. The red is the sham and the blue is the sleeve. And this is changed from baseline HbA1c. And you can see here, there was a greater change in A1c in the treatment group compared to the sham group, with 42% of people coming off their medicines in the treatment group versus only 17 in the sham, and no significant difference in weight loss. Migration was an issue early on, and these numbers didn't quite reach statistical significance, probably because all these people were coming off their meds. Since that time, there have been several other studies, and this is a meta-analysis looking at the result of these. And overall, there's over a 1-point drop in A1C, despite the fact that in most of these studies, the meds were really substantially reduced in the treatment groups. What's more striking, though, is the amount of weight loss you're seeing in these studies, with about a 19% total weight loss in obese diabetics. Now, initially, there was some confusion because many of the studies looked at people that weren't obese, and there's some heterogeneity there. However, if you look at obese diabetics, they also lose a good amount of weight. This device was part of an FDA trial that was stopped early due to hepatic abscess formation. However, it appears they figured this out, and a new trial is underway. There are several other liner-type devices as well, some with different types of atraumatic anchoring mechanisms, and some that anchor in the cardia and go deeper into the small bowel, and they're all in various phases of studies. Next, we have duodenal mucosal resurfacing. And this device really works just by ablating the first part of the small bowel. The advantages here are that there are no implants to be left behind. It appears very safe. There are little channels that run on the outside of this balloon, and you place this over a wire and under fluoroscopic guidance. Then you expand the balloon, pushing those channels a bit into the mucosa, and then you'll aspirate tissue into the channels, and a needle will be advanced, injecting a cushion of fluid in the submucosal space. After this step, the balloon is heated and the mucosa is safely ablated. And this focuses primarily on foregut mechanisms because you're not really doing much with the hindgut here. The initial pilot study was performed in Santiago, Chile. It was a single-arm study looking at 44 subjects. There was 2 groups, one with a short ablation and one with a longer segment ablation. And you can see the baseline patient characteristics here. BMI not that high, just a bit over 30, and HbA1c was rather high, 9.5, so poorly controlled diabetes, not terribly obese. The A1c improved by 1.2% at 6 months across all comers. However, if you look at people that had stable background medicines, so they weren't on a sulfonylurea that you had concern of hypoglycemia and had to be adjusted, they were on stable medicines, those patients had a 1.8% reduction in A1C. And this did persist well after mucosal healing was documented on repeat biopsy. A follow-up study, the REVITA-1 study, was a multi-center study, including sites in Europe and Chile. And you can see the baseline patient characteristics are very similar to the prior group, again with rather poorly controlled diabetes. And again, we have improvement in everything across the board: A1C, fasting plasma glucose, HOMA-IR, and liver tests, which was quite interesting. So we have a drop in A1C of up to 1.4% there. And they also looked at MR hepatic fat fraction. which is quite novel. And they saw a 30% lowering of relative fat and 6% reduction of absolute fat fraction. And they have further studies looking at this that are underway. Moving on to endoscopic anastomosis, or enteral diversion. This procedure requires 2 endoscopes. One placed from below that goes about 100 centimeters above the ileocecal valve, and another from above that goes just beyond the ligament of Treitz. And then once you get the scopes in position, you're going to advance magnets down the channels, and then they self-assemble in the bowel. And then you'll use fluoroscopy to guide them together and push them together here. And then after that, you cut those little sutures and leave the magnets in place. This part does take a little bit of time. And following this, there's pressure necrosis. So the tissue is trapped between the magnets. The blood flow is cut off to this area. So there's pressure necrosis and tissue remodeling around it. This forms a rather large over 2 centimeter fistula. And the magnets will pass on their own out in the fecal stream. And this results in a side-to-side anastomosis. So there's no blind limb. There's two paths there. You have a treatment path, so some food can go directly, from the proximal jejunum there into the ileum, and other food will go in that preserved native path, mitigating against any potential complications. So this really is focusing only on hindgut mechanisms. We're not doing anything to the duodenum. So we have the liners that do both foregut and hindgut. You have the ablative therapies that really focus only on foregut mechanisms. And now we have anastomosis focusing only on hindgut. And again, this is very different than the traditional, old school jejunal ileal bypass, where you had a very long blind limb that led to all sorts of problems. Okay, there is no blind limb in this type of setup. You have a preserved native path. So in the pilot study, for this, there was 10 subjects, 3 were pre-diabetic, 4 diabetic. This was done under laparoscopic supervision. And you can see what the anastomosis looks like here at 2 months. It's well healed, no edema even remaining at that point in time. A1C reduction at 36 months. You see in the diabetics, it went from 7.8 down to 6. In the pre-diabetics, it went from 6.1 down to 5.2. And the weight loss here at 36 months, we have over a 14% total weight loss that was pretty stable and maintained there. This is bioimpedance testing with one of the subjects. You can see yellow is fat, red is muscle, and you can see a significant change in body composition over the course of the study. And she lost 42 kilograms, or 41% total weight loss, and that's what she looked like before. So it can have quite substantial effects. Moving on to another concept, the Satisfier. This has a memory wire frame with mesh balls on this that resides in the duodenum. And the goal here is conceptually to slow duodenal transit of food and alter satiety hormones. They did a randomized pilot study of 31 subjects. 21 received the treatment and 10 were control patients. Average BMI of these patients was over 41. Migration was seen in 10 of those 21 subjects. So certainly some work needs to be done on the anchoring mechanism. And weight loss at 3 months was 6.7 kilograms in the treatment group versus only 2 in the control group. So there was an improved weight loss definitely in the treatment group there. So looking for more information on that in the near future. So what about the overall role of EBTs? Many people, like to show this, where you have different conditions that really have required a spectrum of care to adequately treat them, such as orthopedic conditions and cardiovascular conditions. You have non-invasive therapies like exercise, medications, and whatnot. You have minimally invasive therapies, arthroscopy, and intravascular treatments. And then you have surgery, joint replacement, and CABG. And obesity and diabetes have really lacked that minimally invasive alternative. We have diet, exercise, meds, and surgery, but they don't have that minimally invasive option. And we think that endoscopy certainly fills that. But I think it does much more than just fill that gap. This is another way of looking at the obesity pyramid, if you will, in the United States. We have 19 million people who suffer from morbid obesity and only 1% get surgery. There's another 88.6 million that don't yet qualify for surgery and 97.8 million that are overweight headed that direction. And instead of endoscopy just being a gap therapy, I think we really can help a variety of these people. We have revision procedures that you've heard about that are, effective at treating people with weight regain after gastric bypass or sleeve. We have bridge procedures such as intragastric balloons for people that need heart transplants or knee surgery. We have early interventions or true gap therapies for, people that don't qualify for surgery yet, maybe cosmetic procedures like certain balloons there. And then what we talked about today was, in my lecture, was metabolic therapies for people that may or may not be obese, that have poorly controlled diabetes, and potentially even primary alternatives when you start thinking about combining these different devices and different mechanisms of action. So in conclusion, gut hormones play an integral role in the pathophysiology of type 2 diabetes and obesity. Small bowel procedures targeting these mechanisms are proving to be effective, and procedures that rely on different mechanisms will help to optimize combination therapies in the future. Thank you very much for your attention.